Welcome to this first introductory session in our e-learning module on clinical respiratory physiology. My name is Ronan Berg and I'll be taking you through all of these sessions. I'm a nuclear medicine physician and associate professor of respiratory physiology at the University of Copenhagen. The session are meant to be complementary resources for the course on clinical respiratory physiology and the clinical fellowship program in pulmonary medicine. In these sessions, certain aspects of respiratory physiology will be discussed in more detail than is possible during the actual course. We have chosen topics which we either consider particularly important or topics that many course participants usually find very difficult. So the purpose of this introductory session is to provide a general overview of the respiratory system. After having completed this first session, you should have obtained a general overview of the respiratory system and respiratory function as such. Furthermore, you should be able to describe the distinct steps that are encompassed in so-called external respiration. Now, respiration is a general term that encompasses the transport of gases from atmospheric air to the tissues and back again. It is divided into external respiration and internal respiration. So external respiration is actually the transport of gases from atmospheric air into the tissue level and back again. So that would be oxygen from the atmosphere to the tissues and carbon dioxide from the tissues and back to the atmosphere. Internal respiration would be the processes that subsequently take place within the mitochondria. And by convention, external respiration is what we are working with in respiratory physiology, whereas internal respiration belongs within the field of biochemistry. So everything we talk about during this course and in these online sessions considers external respiration. And generally, when we're talking about respiratory physiology and breathing, we'll be talking about external respiration. Now, external respiration can be divided into a number of processes, which each involve convection and diffusion. So convection, that would be the transport of gases due to either aerostatic or hydrostatic pressure gradients. And diffusion would be the movement of these gases due to concentration differences or partial pressure gradients. So, with breathing, air is moved from the atmosphere to the alveoli, mainly by convection. So that is pressure changes between the atmosphere and within the alveoli is accounts for the transport of gases to this level. And actually, there's a small bit of diffusion there as well from the level of the terminal bronchioli to the actual blood gas barrier that occurs by diffusion, but it's mainly convection. Then transport of the gases across the blood gas barrier or the alveolar capillary membrane occurs by diffusion, and this is what we generally call pulmonary gas exchange. That is the diffusion of gases across the blood gas barrier. Then the cardiovascular system generates hydrostatic pressures within the vasculature that transport blood with these gases between the heart and lungs and the tissues. So that would be convection again. And then at the capillary and tissue level, the gases are again transported by diffusion. So external respiration is all about convection and diffusion. So let's take an overall view at the respiratory system, which consists of several elements, which I've tried to show here. And we will go through most of these during these online sessions, and we touch on all of them during the actual course. So we have the airways and the lungs. There's the cardiovascular system. The kidneys are also involved, and so is the central nervous system. So let's see what actually happens during normal breathing. Well, within the central nervous system, in the brainstem, a respiratory rhythm is generated. This provides output to the respiratory muscles and generate a basic spontaneous breathing rate and tidal volume. So this leads to a given minute ventilation, which we write in this manner here. Some of the ventilation stays within the anatomical dead space, and we call that dead space ventilation, that does not participate in pulmonary gas exchange. The rest actually reaches the alveoli, where gas exchange occurs. Alveoli ventilation subsequently gives rise to a partial pressure of oxygen within the alveoli, PaO2. And from the alveoli, oxygen is then transported into the pulmonary capillary system by diffusion. This ultimately, which then gives rise to given oxygen uptake in the body. All the oxygen in the human and all mammalia occurs by pulmonary gas exchange. This then gives rise to an arterial oxygen tension at the systemic level, and also a saturation in the systemic circulation. And then gas exchange occurs again within the capillary network of tissues. Because of this, of these metabolic processes, carbon dioxide is produced within the tissues, and carbon dioxide is then transported back to the lungs, where it is released again by diffusion. And within the alveoli, this gives rise to a given alveolar carbon dioxide tension, or partial pressure of carbon dioxide. As the blood passes through the pulmonary capillary network again, this also ultimately gives rise to the partial pressure of carbon dioxide within the systemic systemic arterial blood. And because CO2 is closely linked to acid-base homeostasis in the body, this is also of importance to the systemic pH levels. An important point in this system is that the respiratory rhythm generated to start with within the central nervous system does not provide an adequate minute ventilation for the metabolic needs of the body per se. They're not matched, so to speak. But due to the chemoreceptor system, which is present in the systemic arteries, which sense both PaCO2, and pH, this provides feedback to the central nervous system, which then matches ventilation, or drives ventilation, so it is subsequently matched with the metabolic needs of the body. So there's what we call a continuous respiratory drive in the healthy state due to feedback, which kicks what we call the central pacemaker network within the central nervous system to generate an adequate minute ventilation to meet the metabolic needs of the body. Now, this chemoreceptor system is sensitive to both oxygen, carbon dioxide, and pH, but actually The main driver under physiological conditions is CO2. Now, I just said that these chemoreceptors are present in the systemic arterial system, but that's not entirely true. There's also a central chemoreceptor within the CNS, which is actually quantitatively the most important of these chemoreceptory systems. So there are two, both central and peripheral chemoreceptors, which contribute to this. And it turns out that the main driver is actually CO2. So the system is sensitive to both oxygen and carbon dioxide and pH, but the main driver is CO2. So CO2 or the arterial partial pressure of CO2 continuously drives ventilation through the chemoreceptory system and ensures that ventilation is matched with the metabolic needs of the body. Subsequently, the arterial CO2 is actually kept relative quite constant in the human body. So you could say that that the respiratory system as a whole is targeted at maintaining CO2 constant, which has both implications for oxygen uptake, but also acid-base homeostasis in the body. Now, what I'm referring to here is what we call CO2 centrism. So, the point of view that carbon dioxide is central to respiratory function as a whole. And I'll be getting back to the graph that in later sessions, the graph that I've shown here. But what it shows is both alveolar ventilation as a function of PaCO2 and PaCO2 as a function of alveolar ventilation. So the gray curve here would show shows PaCO2 as a function of alveolar ventilation. When alveolar ventilation is increased, PaCO2 decreases because CO2 is washed out from the lungs, as we call it. When ventilation decreases, PaCO2 increases. Conversely, the dashed blue line shows ventilation as a function of PaCO2. So this graph is actually showing chemoreceptor feedback. So it shows that when PaCO2 increases, this will cause reflex increase in ventilation. And in a given person, ventilation will be set where these two graphs cross each other. And from this, you can also see that you need to have a shift in one of these curves for PaCO2 to deviate. Keeping in mind that when it comes to breathing, these basic reflexes and mechanisms can, in many cases, be overruled by voluntary hyper or hypo ventilation. But setting that apart, this shows how and why PaCO2 is so tightly regulated in the human body. And we'll be getting back to this graph later on. But basically, this is all about what we call respiratory drive. So the point that the central pacemaker network that generates the respiratory rhythm within the brainstem needs to be continuously stimulated by CO2 feedback, both from peripheral and the central chemoreceptor, for it to generate an adequate minute ventilation, adequate for the metabolic needs of the body. All right, so just to sum up, external respiration is the focus of respiratory physiology, and it considers the transport of oxygen and carbon dioxide between atmospheric air and tissues, and all the mechanisms involved in that, which are all related to either convective or diffusive processes. Yes. So to understand this this topic adequately, some self-study is necessary. And I recommend that you revisit the relevant physical laws, Dalton's law, Henry's law, and the ideal gas law. Furthermore, I recommend that you take a look at some of the very central concepts and the definitions of them and how you distinguish them, notably ventilation and pulmonary gas exchange. When it comes to ventilation, it's also important to understand what dead space ventilation is, and therefore also what anatomical, alveolar, and physiological dead spaces and how these are related. I also recommend that you take a look at the limiting factors for pulmonary diffusion in humans, and that you work out what the appropriate values for oxygen tension and CO2 tension is at the various levels of respiration, that is from the atmosphere and all the way to the tissues and back to the lungs again in the mixed venous blood. You can either do this by looking this up all up online, or looking at some of the classical physiology textbooks. I recommend that you take a look at the two textbooks by John West, the most recent editions, both his respiratory physiology book and his pulmonary pathophysiology textbook. And furthermore, I recommend that you take a look at this a chapter in the Handbook of Physiology from 1987 by Kellogg, which deals specifically with the laws of physics relating to this. It's rather important to understand them to actually get a grasp of respiratory physiology. All right, that's all from this first session for now. Thank you for listening. Welcome to the second session in this online module in clinical respiratory physiology. Now, this session will focus on the mechanics of respiration. And when we're talking about mechanics, it ultimately relates to factors that may limit ventilation in the lungs. So the first step of external respiration, which I talked about in the previous session. I won't be going through ventilation in detail, but what I will be talking about is two curves which are traditionally considered rather difficult to understand and to grasp, and that's the respiratory relaxation curves and the isovolemic expiration curves. So the objectives of this session is for you to understand the physiological basis and to interpret respiratory relaxation curves, and also to understand the basis and to be able to interpret isovolemic expiratory curves. You're all familiar with these compliance curves. So the definition of compliance is change in volume per change in pressure. So when we have a classical compliance curve, this one, we have a pleural pressure at the x-axis and lung volume at the y-axis. Compliance is the slope of this curve. and you can see in this curve that compliance is not constant. It actually decreases at both large and low lung volumes. And that is because the lungs become less compliant, or the whole system becomes more plastic, as we call it. And that's because compliance of the lungs, a major determinant of that is the three-dimensional organization of the collagen and elastin fibers. But at very low lung volumes, they're completely compressed. So I've just imaged a spring up here to illustrate it. So you can see here at low lung volumes, the basis of compliance disappears because the lung just becomes completely compressed, and thus it becomes non-compliant or plastic, as we call it. At very high lung volumes, all the fibers stretched, which also means that the lungs become stiffer, and thus that compliance decreases. What we can also see on this curve is that it differs between inspiration and expiration, and that is mainly due to the effects of the surface tension of the lining fluid and in the alveolar compartment. If there was no surfactant within the lungs, the area within this curve would be much larger. Furthermore, it should also be noted that this curve illustrates the extremes of lung volume, so from residual volume and all the way up to total lung capacity. And clearly that's not where normal breathing takes place. Normal breathing takes place here around the functional residual capacity, where the difference between inspiration and expiration is less. And normally when we talk about compliance of the lungs, we would consider it the slope here between these two graphs, just above functional residual capacity. But when we're looking at the respiratory system in vivo, it's not only respiratory compliance is not only about the lungs. It's actually it depends both on the compliance of the lungs, but also of the chest wall. So we have got two compliance systems, and actually you could say that these two systems are competing with each other because in many cases their elastic recoil forces oppose each other. Just to say here that the compliance of the whole respiratory system depends both on the compliance of the lungs and of the chest wall, which is what I've shown down here. The compliance of the respiratory system as a whole, it is calculated on the basis of inverse values, and that's why the compliance of the respiratory system is actually less than the compliance of the two individual components. This brings us to the relaxation curve of the respiratory system, which I've shown here. So at the x-axis there's pressure within the airways, and at the y-axis there's a lung volume. Now this graph shows what happens when a person assumes a given lung volume and the airway then is closed. So when the airway is closed, the pressure within the airway becomes a function of the elastic recoil pressures of the respiratory system. So if the respiratory system With that I mean the lungs and the chest wall as a whole want to contract, become smaller. The airway pressure will be positive. If the respiratory system wants to expand, the airway pressure will become negative. And on this graph, you can see the solid line here, and that is the airway pressure for the respiratory system as a whole. That's also what we call the total recoil pressure, or the relaxation pressure of the respiratory system. This curve is in fact a function of two other curves. So that is this curve here, the dash curve here, hold on. This curve here, this PL. So that curve shows the pulmonary recoil pressure. So this curve is the contribution of the lungs per se. So again, same story again. When the value is positive, it means that the lungs want to contract, want to become smaller. They're compressing the air in the airways. When negative, it means that the lungs want to expand. As you can see, it's actually never negative. It ends at 0 here. The other dashed line here is this one here, PW. This curve shows the contribution of the chest wall. So that's the recoil pressure of the chest wall. Again, when negative, the chest wall wants to become to expand, and when positive, the chest wall wants to get small. So in this way, we have we're visualizing actually the competing influences of the elastic recoil pressure of the lungs and of the chest wall, and how they together affect total lung volume ultimately, because lung volume is what we have at the x-axis here. So let's start off here where the solid line crosses the y-axis here. That's actually functional residual capacity. So as this subject here assumes functional residual capacity and closes the airway, the pressure within the airway is 0. And that's because the opposing forces, the lungs want to expand, and the lungs want to contract or become smaller. The chest wall wants to expand, but they're in balance. So there are no opposing forces, or they're in balance. So the net pressure, the total recoil pressure, becomes 0. So the point where this line crosses 0 here is the functional residual capacity. So what happens up here? Oh, and you can see that here. This is the this here is the recoil pressure of the chest wall, and this here is of the lung, and they're at equal distance from 0 here. So the net value between the two of them, or the sum of them, becomes 0. Okay, so let's increase lung volume to total lung capacity. Now at total lung capacity, what we can see is that there's a high relaxation pressure, high total recoil pressure. So the whole respiratory system really wants to become smaller, so to say, at total lung capacity. And that's because both the lungs and the chest wall are expanded beyond the resting volume. So the contribution of the lung is this elastic recoil pressure here, and of the chest wall is this elastic recoil pressure here, and the sum of them is the total recoil pressure of the lungs. So if the subject then expires all the way to residual volume, what happens then? Well, at residual volume, the chest wall is actually compressed. It's smaller than its normal resting volume. So the elastic recoil pressure of the chest wall becomes negative. At residual volume, the lungs actually compressed to their resting volume, so their elastic recoil pressure becomes 0. So the sum of the two becomes the relaxation pressure, which is then equal to the chest wall recoil pressure. So I hope this makes sense to you, and that this graph at any lung volume shows the competing recoil pressures of the chest wall and the lungs, because at some lung volumes they both want to become smaller. At some lung volumes only the lungs want to become smaller, and at others again only the chest wall wants to expand. So let's apply this to a clinical condition, emphysema. What happens in emphysema? Well, that's what I tried to show here. So in emphysema, there's a destruction of lung tissue and a loss of collagen and elastin fibers within the three-dimensional structure of the lung parenchyma, which means that compliance increases. When compliance increases, that means that the recoil of the lung tissue decreases. And on this curve here, this would be shown as a left shift of the pulmonary recoil pressure curve. So that's what I've shown here with the blue dashed line. That's supposed to show a left shift of the normal pulmonary curve. And let's assume just for now that the chest wall recoil pressure is unaffected by emphysema, which is more or less true. What then happens to the total recoil pressure of the chest, of the respiratory system? Well, the solid line is always supposed to be the sum of the chest wall and the pulmonary chest wall recoil curve. So in this instance, it means that the relaxation curve for the total respiratory system is also left shifted. And this actually has an imminent effect on functional residual capacity, because that was the point where the curve crosses the 0 line here. And before, with interchange and compliance, functional residual capacity was here, but now it is shifted to this point here. So here you can see how an increase in pulmonary compliance without any changes in chest wall compliance increases functional residual capacity, and in fact also total lung capacity. But this is actually this here is relative volume, it's percent of vital capacity. So you can see that the functional residual capacity makes up a larger proportion of vital capacity. Yes, another example is pathological reduction in pulmonary compliance, which is what we see in pulmonary fibrosis. Under these circumstances, the pulmonary recoil pressure curve will be right shifted, which is what I've tried to show here. And so this curve is shifted to the right over here, because um, a reduction in compliance is the same as an increase in pulmonary recall pressure under these circumstances here. So again, assuming that there are no changes in the recoil pressure or the compliance of the chest wall, what then happens to the relaxation pressure and thus the compliance and volume of the respiratory system as a whole? Well, it means that this solid line here is also shifted to the left, because again, this line is the sum of the pulmonary recoil pressure line and the chest wall recoil pressure line. And again, we can see that something very important happens in terms of functional residual capacity. It's located here without any change in pulmonary compliance. It shifts downwards by the reduction in pulmonary compliance, which is pathognomic for any restrictive lung disease, really, including pulmonary fibrosis. So this illustrates how a reduction in pulmonary compliance actually causes a reduction in functional residual capacity as a fraction of vital capacity, and as a consequence also a concomitant reduction in total lung capacity, which we see in restrictive lung diseases. Now, this is an example of pulmonary restrictive lung disease. Let's see what the story is in extrapulmonary restriction. So, in extrapulmonary restriction, let's assume that there are no changes in pulmonary compliance per se. What happens to chest wall compliance? Well, the chest wall curve will be shifted to the right, which is what I'm trying to show you. So this dashed line here is the chest wall recoil pressure line. This basically just shows that the elastic recoil pressure of the chest wall has increased, or perhaps more accurately, that compliance of the chest wall has decreased, which may indeed be a mechanism of extrapulmonary restriction, not the only, but an example of that. The point here is that the total recoil pressure line here is, as always, the sum of the two other lines. And this example here, this is just for the sake of example, we actually achieve the same reduction in functional residual capacity. So it's here without any change in chest wall compliance, and it's shifted to this point here with this pathological change in compliance, this pathological reduction in compliance. So now we'll move from the respiratory relaxation curves to the so-called isovolemic flow pressure curves. And I just want to show or explain what this classical graph actually shows and what the physiological implications of that is. So in this curve, there's expiratory flow, and that's actually the maximal expiratory flow obtained during a forced expiration on the y-axis, and the x-axis there is pleural pressure. Now, a point here is that pleural pressure depends on expiratory effort. So imagine that a person assumes a given lung volume and then expires with different efforts. And for each effort, he achieves a different pleural pressure. That's actually what's shown here. So each of these curves, a person has started off from a different lung volume and has conducted a series of forced expirations with different efforts. So, for example, the A line here is not one forced expiration, but it's one starting volume, which corresponds to a pleural pressure of minus 17 or 18 centimeters of water. And then a series of expirations with different efforts corresponding to a change in pleural pressure is performed, and on the basis of this, a line is then drawn across all these efforts. Okay, let's start with the A line. Here at the A line, the individual is at a volume that is 90% of his or her total lung capacity. And the subject performs a series of forced expirations. So let's see, just for the sake of example, with the first forced expiration, the first forced expiration is delivered with only a slight effort. So pleural pressure does not even become positive, but perhaps it becomes minus 15. And then this maximal expiratory flow is achieved. Next time he or she blows a bit harder to a pleural pressure, for example, of minus 10 centimeters of water, and then this flow is recorded. Blows a bit harder again, this flow is recorded, and so on. And what we can see here is that when the person is at a starting volume that is very close to total lung capacity, the maximal expiratory flow that is achieved appears to depend on effort, appears to depend on how high a pleural pressure that's achieved during the maneuver. Right. So next curve here, B. Now the starting volume is at 60% of total lung capacity. That corresponds to a pleural pressure to start with of minus 10 centimeters of water. Here, on what I've shown here is the alveolar pressure just before the expiration, pleural pressure here, and transpulmonary pressure here, which is different between the two. Okay, so a series of forced expirations. First with an effort, so that pleural pressure changes from minus 10 to minus 7. Next from minus 10 to minus 1. Then this maximal flow is achieved. Then a forced expiration where the pleural pressure becomes 5 centimeters of water. This flow is achieved, and so on for a series of forced expirations. And what you can see here is that initially the maximal flow increases with increasing effort, with increasing pleural pressure. But at some point it reaches a plateau. So even though the person blows harder, this does not result in a higher flow. Graph C, the starting volume is even smaller, 50% of total lung capacity, corresponding to a pleural pressure to start with of minus 5 centimeters of water. This is close to, or actually below functional residual capacity. Okay, so same story again. A series of expirations at different efforts, and the maximal expiratory flow is recorded. So what you can see here is that a plateau is reached again. So even though the person blows harder and harder, at some stage this does not result in higher flows anymore. This is essentially what the graph is showing. And And this illustrates that flow limitation occurs even in the healthy lung, and that this sets in not at high lung volumes, but at mid and low lung volumes. So flow limitation is an important pathophysiological mechanism in obstructive lung diseases, but it does actually play a role even in the healthy state. It just does not set in until moderate to low lung volumes are reached, and it does not limit flow to such an extent that it has any functional implications. These graphs are based on a paper by Donald Fry, and in the same paper he also performed similar measurements in patients with emphysema, and I'm just drawn them here as well. And these are again A, B, and C. Again, it's approximately 90, 60, and 50% of total lung capacity. And what this shows is, one, much lower flows are reached in a patient with emphysema, which corresponds with the fact that they've increased airway resistance. At the same time, the plateau is reached very early on, and it's reached even at large lung volumes, so even at 90% of total lung capacity. You can also see here that even though patients with emphysema have very large lungs, they achieve very low flows. The flows are actually quite similar despite different starting volumes. And flow limitation sets in early on. All of this basically illustrates this point that I've also shown here on this flow volume curve obtained during spirometry, because during a forced expiration, alveolar pressure keeps increasing even after peak flow is reached. So even though alveolar pressure increases, which is a function of the compression of the airways, and thus the increase in pleural pressure, flow does not increase, but it actually starts to decrease. This is also the case in emphysema, but as you know, emphysema curves look much different. They've got this concave configuration, and much lower flows are reached. So imagine that the same alveolar pressure profile occurs in a patient with emphysema. Well, the resultant flows will be much lower and will start decreasing much early on, and at a given alveolar pressure, a lower flow is achieved throughout, from large lung volumes, total lung capacity to start with, all the way down to residual capacity. So this again illustrates the concept of flow limitation, which occurs during increased airway resistance. And to understand how that develops, or the mechanisms of that, you need to study either the dynamic airway compression theory or pressure wave theories, which I will not go into details with here. So in summary, respiratory relaxation curves show how changes in pulmonary and chest wall compliance ultimately affect lung volumes. And the isovolemic expiratory curves, they show how both starting volume of the lungs and the expiratory effort per se, how they together affect expiratory flow, and these thus illustrate the concept of expiratory flow limitation. In terms of self-study objectives, I recommend that you study dynamic and static lung volumes and capacities rigorously, and with that also study the factors that can increase and reduce pulmonary compliance, and I mean from a mechanistic or pathophysiological point of view, not a disease-specific point of view per se. Try to uncover or detail, make a simple overview of the mechanisms that may increase airway resistance, and also those that can reduce lung volume. And this goes hand in hand with the factors that affect lung pulmonary compliance, but these are not the only factors that may cause these changes in airway resistance and reduced lung volume. And this basically relates to the fundamental mechanisms of obstructive and restrictive lung disease. As I mentioned before, I also recommend that you study both dynamic airway compression and the equal pressure point. That's one theory that explains the concept of flow limitation. Another competing theory, which more accurately actually describes flow limitation more accurately, but is somewhat more complex, is the pressure wave theory, which includes the so-called tube law, and in which the concept of a choke point in the airways is introduced. To achieve this, I recommend these papers here. In particular, this review by Ole Pedersen and Butler, this nicely explains the mechanisms of flow limitation, and also touches upon the curves I've reviewed in this session here. But all the other papers here are also worth a read. All right, that ends this session. Thank you for listening. Welcome to this session on the physiology and diagnosis by spirometry of upper airway obstruction, which is part of the e-learning module in the clinical respiratory physiology course. In our real-life session on lung function testing, we do not have the time to go into upper airway obstruction, and therefore I will go into a bit of detail with that here, just to illustrate why it can be assessed the way that it can. When we're talking about upper airway obstruction, we're talking about any obstruction from the larynx and to the level of carina. And these may either be variable, that is the change between inspiration and expiration, or they may be fixed, and when fixed, they both cause obstruction during in and expiration. Furthermore, they may be extrathoracic, so that means that they're placed in the part of the trachea or the larynx, from the larynx and until the part of the trachea that's outside the chest cage, whereas intrathoracic obstructions are placed in the trachea, the part of the trachea that's within this chest cage. So the objective of this session is for you to be able to distinguish between variable extrathoracic obstruction, variable intrathoracic obstruction, to distinguish them from each other, and from fixed upper airway obstruction. Now, with fixed upper airway obstruction, it's not possible to distinguish between intra and extrathoracic. So they may be either of the two. We'll start out with the variable extrathoracic obstruction. First of all, I want to introduce to you the so-called MP's index. MP's index is the ratio between FEV1 and peak expiratory flow. Now, it's from a classical paper, and in that paper, FEV1 was reported in milliliters and peak expiratory flow in liters per minute. And using those units, an MP's index of more than 8 was found to indicate upper airway obstruction. At least in my unit, we usually report FEV1 in liters and peak expiratory flow in liters per second. And if those units are used, the value becomes 0.5. So an MPS index of more than 0.5 indicates upper airway obstruction. The diagnostic rates of MPS index have not, to my knowledge, been evaluated. So it should not be considered definitive, but it suggests the presence of upper airway obstruction. It does not distinguish between variable, extra, intra, or fixed upper airway obstruction, but it merely points towards the presence of upper airway obstruction of any kind. So when it comes to distinguishing between the specific subtypes, two things must be done. First of all, the flow volume curve during a spirometry test with both forced expiration and forced inspiration must be visually inspected, and the so-called FEV ratio must be calculated. FEV 50 here means, hold on, this ratio here is what I'm talking about, and FEV 50 means forced expiratory flow at 50% of vital capacity. And if we look at our flow volume curve here, we have vital capacity here, right? And so 50% must be somewhere around here. And the forced expiratory flow at 50% of vital capacity must be this value here. FEV 50 is forced inspiratory flow at 50% of vital capacity. So that's this value here. So what we're showing is basically the ratio between the two when we're calculating this FEV ratio. But let's first consider what actually happens in the airways if there's a variable extrathoracic obstruction. So it's an obstruction in the part of the trachea that's located outside the chest cage. So in these parts of the airways, pressure within the airways becomes very positive during a forced expiration. So that will minimize the effect of the obstruction. In contrast, the obstruction will have a more prominent effect on flow during inspiration, because during a forced inspiration, flow within the airway becomes very negative. So in that sense, it will amplify the effect of the obstruction and thus limit inspiratory flow. And therefore, we get this configuration of the curve with a normal forced expiration curve, but a somewhat flat, we call it box-shaped inspiratory curve. And we quantify that by calculating the ratio between the FEV 50, the FEV 50, and if that value is higher than 1.0 or 100%, sometimes it's reported as percent, and in some senses they even use a cutoff value of 120%. But in any event, if that value is high, that's basically a way of showing that the inspiratory curve is flat relative to the expiratory curve, and thus also pointing towards variable extrathoracic obstruction. So these three things together, and in a high MPS index, a box-shaped inspiratory curve with a normal expiratory curve, and a high FEV ratio together indicate the presence presence of variable extrathoracic obstruction. So how do we prioritize between these three? They all need to be fulfilled for us to make the diagnosis. No problem. The most important thing is actually the visual inspection of the curve, and the FEV ratio should merely be considered a means of quantitating that. And I think the MPS index is probably a somewhat unspecific index. But if all three are present, one can be somewhat confident that extrathoracic obstruction is present. But even if the FEV ratio is normal and MPS index is normal, and the patient has performed an adequate forced inspiratory maneuver and it's box shaped, I would still suspect extrathoracic obstruction. Let's move on to a variable intrathoracic obstruction. That is an obstruction in the aspect of the trachea that's located inside the chest cage. Now, during a forced expiration maneuver, pressure inside the chest cage and thus around the aspect of the trachea that's located inside the chest cage becomes very, very positive. So it will compress that part of the trachea. And thus, if there's an obstruction present there, this will magnify the impact of that on flow. So expiratory flow will be limited. In contrast, pressure around the intrathoracic trachea becomes very negative during the forced inspiration, and that will alleviate the effect of the obstruction. So because of that, we'll see this type of flow volume curve with low flow during the forced expiration, but a normal and somewhat round curvy inspiratory curve. So again, MPS index may be increased because that indicates that there's an upper airway obstruction. By visual inspection of the curve, the inspiratory curve will be normal, but the expiratory curve will be flat, box shaped, and the FEV ratio, which again is the ratio between probably these two values here. So forced expiratory flow at 50% of vital capacity divided by forced inspiratory flow at 50% of vital capacity will be reduced. So it'll usually be less than 0.3 or 30%. So together, these three things: increased MPS index, a flat expiratory curve, normal inspiratory curve, and a reduced FEV ratio will indicate the presence of intrathoracic obstruction. This leads us to the fixed upper airway obstruction. So this is a type of airway obstruction that's fixed in the sense that it limits both flow during in and expiration. Again, MPS index will be increased, but under these circumstances, flow will be limited both during in and expiration, so both will become somewhat flat or box shaped, as you can see here. And in fact, when we quantitate this by the FEV ratio, it becomes normal. It's normally between 0.3 and 1.0. So yeah. So that's that. That's how a fixed upper airway obstruction looks. Very important. The most important thing here again is the visual inspection of the flow volume curve, because that will unveil the flat inspiratory and expiratory curve. By looking at this ratio per se will not really give anything away. So in summary, the presence and location of airway obstruction, as well as the classification of it being variable or fixed, depends on MP's index, visual inspection of the curve, which is the most important thing, and the fifth ratio. I recommend that you study the causes of both extrathoracic and intrathoracic upper airway obstruction. Although they may give rise to similar symptoms, the underlying disease states are typically somewhat different between the two. Furthermore, please consider which complementary diagnostic modalities you would use when you encounter evidence of upper airway obstruction on spirometry. For this, I recommend that you read these papers to start with, both the classical paper by MP and also these two other classics where this methodology is critically evaluated. Somewhat old papers, but I would consider them classics. Thank you for listening. Welcome to this session on the alveolar arterial oxygen difference, which is part of the e-learning module of the course in clinical respiratory physiology. The alveolar arterial oxygen difference is abbreviated AADO2, and it is a fundamental physiological index of the efficiency of pulmonary gas exchange. With this session, you should be able to define AADO2 and to describe the factors that actually determine AADO2. Among these factors, you should specifically be able to understand how an unequal distribution of ventilation within the lungs relative to the distribution of diffusion contributes to this alveolar arterial oxygen difference. Let's first take a look at the oxygen gradients in the respiratory system. For starters, the oxygen tension, or the partial pressure of oxygen in atmospheric air, is 21.3 kilopascals. By the time it enters the airways, it's warmed up and vaporized, and that actually reduces the partial pressure of oxygen slightly to 20 kilopascals. This air then enters the alveoli and contributes to an alveolar oxygen tension of 13.3 kilopascals. Now, this PaO2 is a product of two things. It's a product of the oxygen or the air entering the alveoli from the atmosphere, as well as the oxygen that's removed from the alveoli by pulmonary gas exchange, and then ends up at 13.3 kilopascals. The oxygen leaves the alveoli and enters the blood by diffusion, and more or less complete diffusion equilibrium sets in, so the end capillary oxygen tension is actually the same as in the alveoli. It's slightly lower, but not something that we can measure on the first decimal at least. When we get to systemic arterial blood, the oxygen tension is actually slightly lower than in the alveoli. So here in this example, it's 13 kilopascals. Within the systemic capillaries, it's reduced because here it's a product again of two things: the oxygen that enters the capillary bed, as well as the oxygen that's removed from the capillaries and enters the tissues for the purpose of metabolism. Mixed venous blood has an oxygen tension of approximately 5.3 kilopascals in the healthy resting state. So blood with an oxygen of 5.3 kilopascals enter the pulmonary capillaries, and then meets an alveolar oxygen tension of 13.3 kilopascals, so that it is increased to the same level. Yes. All right. And all these processes of pulmonary gas exchange take place by diffusion and diffusion alone. You say that the lungs built for diffusion and thus for gas exchange. An interesting question, though, is that it's the blood that feeds tissues that ultimately need the oxygen. And why is the oxygen tension in arterial blood lower than in the alveoli? If you had a perfect respiratory system, they should be the same, shouldn't they? But it turns out that there's a physiological difference between the alveolar oxygen tension and the arterial, and that's what we call the AADO2. It's basically just the difference between the two. You can either calculate the PaO2, the alveolar oxygen tension, by the alveolar gas equation, or you can measure it, and the arterial oxygen tension can obviously be measured in an arterial blood gas. And in normal humans, it's usually normal young individuals, at least, it's usually between 0.3 and 1.5 kilopascals. And this indicates that pulmonary gas exchange is good, but it's not perfect, because if it was perfect, there would be no difference between the alveolar and the arterial oxygen tension. So the reason why the AADO2 is not zero, not even the healthy state, is the contribution of three mechanisms. And I've written them here. So firstly, there's an uneven distribution of ventilation relative to perfusion in the healthy upright lung, and that actually increases the difference between the arterial and alveolar and arterial oxygen tension, and that's it accounts for the majority of this difference. Now, this is in my experience the most complex of the three mechanisms here to understand, and I'll get into detail with it in a minute. For now, I'll just mention that there are other contributors, and the most important, apart from the ventilation perfusion distribution, is anatomical right to left shunting of blood. So blood that bypasses the pulmonary capillary network and thus does not undergo gas exchange. And this involves the bronchial circulation and some small veins within the myocardium. So that's also an important mechanism, but not quantitatively the most significant one. As mentioned, the capillary and alveolar oxygen tension, they are more or less the same, but there is a slight difference between the two on the second decimal normally. So there is a contribution from diffusion limitation. There must be, because there has to be a diffusion gradient for diffusion to occur, obviously. But diffusion limitation is not important in the healthy resting state. Right. So let's go into the pulmonary ventilation perfusion relationships. What I've shown here is the healthy upright lung. I've shown ventilation, perfusion, and the ventilation perfusion ratio. This over here is supposed to show the ventilation perfusion ratio, which ultimately determines regional pulmonary gas exchange. But to start over here by ventilation. In the healthy lung, there's a gradient for ventilation. It increases from the apex to the basis, so it's slightly higher in the basal parts of the lung than in the apical part of the lung. And that's because the compliance of the lung tissue increases, so it's more easily expanded in the basal parts of the lungs at a given change in pressure during normal tight breathing. This is actually because of a gradient in the pleural pressure, which again is caused by the weight of the lung itself. Because of this, the pleural pressure is less negative in the basal parts of the lungs, because the lungs compress the pleural space, so to say, so the pressure there becomes less negative than the apical parts of the lungs, and therefore the lungs are more expanded in the apical parts than the basal parts. And a more expanded lung is less compliant than a less expanded lung, and therefore compliance is high in the basal parts, and we get a slight ventilation gradient. In terms of perfusion, there's also perfusion gradient, and that's also because of the impact of gravity on perfusion. It's not from a vascular or hemodynamic point of view a very well-regulated circulation within the lungs. It's actually rather pressure passive. So therefore, when the right lung is upright, blood is pulled from the apex towards the basal lung, and we thus get a perfusion gradient as well. And as you can see here, in the healthy lung, the perfusion gradient, which I've shown here, so this is we have the ventilation gradient here and the perfusion gradient here. It's quite a funny way of showing it, but this is how it's classically shown. So in this direction, ventilation increases. This direction, perfusion increases. Apex here, basis here, so this basically shows the height of the lung here and here, right? So ventilation increases, perfusion increases more. Perfusion is more gravity dependent than ventilation. The ventilation gradient is still caused by gravity because the pleural pressure gradient I just talked about is caused by the weight of the lung itself, and thus per definition by gravity. But the subsequent effect of ventilation is smaller than that on perfusion. And that means that the ventilation-perfusion ratio is not the same throughout the lung. For perfect gas exchange, we need a ventilation-perfusion gradient of around, actually the perfect VQ ratio would be 1. And you only have that in this part of the lung here. That's a VQ ratio of 1. And I've actually shown the VQ ratio here. Again, it increases in this direction. We've got the apex of the lung, the basis of the lung, and you can see that's only a small area of the lung with a VQ ratio of 1. So in the apical parts of the lungs, ventilation is much higher than perfusion, resulting in a VQ ratio of 3.3. So ventilation is 3.3 times higher than perfusion. And the basal parts of the lungs, it's the other way around. Down here, perfusion is much higher than ventilation, or not much higher, but 60% of ventilation. So you get a ratio of 0.6. Sorry, I mean that ventilation is, of course, 60% of perfusion in the basal parts of the lungs, so it's smaller. And this gradient in the VQ ratio, or these large areas where the VQ ratio deviates from 1, means that the gas exchange becomes less effective. Let me show it to you in a different way. So what the VQ ratio does is actually that it determines the regional alveolar oxygen tension. So if we have a lung here, I put the VQ ratio over here. It goes from to 0 to infinite. And in the normal lung, we have a VQ ratio at the apex of 3.3. So ventilation is higher. That means that ventilation is higher than perfusion. That means that the air within the alveolar becomes is more dominated by the inspired air than by the blood that perfuses through this area. So blood that leaves this part of the lung has a relatively high oxygen tension of around 18.5 kilopascals. At the basis of the lung, the VQ ratio was 0.6. That means that the alveolar oxygen tension decreases because it's less dominated by the inspired air than it is by the blood that enters through the pulmonary artery, enters the capillary circulation. This may be somewhat difficult to grasp, but let's imagine what happens if you go to the extremes. So if you have an infinite VQ ratio, that is a ventilation area with no perfusion, what would happen with the air in that area? Well, the air would only be affected by the inspired oxygen tension and thus be around 20 kilopascals. Conversely, if you had a VQ ratio of 0, that is an area of the lung that's perfused but not ventilated, this inspired air with 20 kilopascals of oxygen would not affect the alveolar oxygen tension in that area of the lung at all. It would only be the blood, and thus the alveolar oxygen tension would be 5.3 kilopascals, and so what would the oxygen tension in the blood leaving that area of the lung. So although less extreme in the normal lung, we have such gradients. So in the upper part of the lung, the alveolar oxygen tension and thus the oxygen tension in the capillary blood leaving the lungs is more dominated by the oxygen tension in the inspired air, and vice versa at the basis of the lung. So if there was a perfect and even distribution of ventilation and perfusion, there would hardly be any alveolar arterial oxygen difference at all. There will only be that caused by the slight amount of right to left shunting in the healthy state, and that's because if ventilation and perfusion was similar in all parts of the lungs, a similar capillary oxygen tension will also be achieved in all parts of the lungs, and that would actually, if the VQ ratio was 1, would lead to more or less perfect gas exchange. However, that's not the case. As I just showed you, there are areas of the lungs which have a higher ventilation and perfusion. That's what I've tried to show here, with a large alveolus and a small vessel feeding it, so that's a high VQ ratio. And we have areas with a low VQ ratio, which I've tried to show with a small alveolus and a larger vessel. So that's a high VQ ratio area and a low VQ ratio area. That could be the apex of the lung and the basis of the lungs. This could be any two lung units. So why does this area here with a high VQ ratio not just compensate for the low VQ ratio area? Well, that's because we have a high alveolar oxygen tension in this part of the lung here and a low here. But this area over here has a very low perfusion, so it contributes less to the blood leaving the lungs in contrast to this one over here, which has a relatively high perfusion. So this area here contributes more to the blood leaving the lungs, and thus the blood that ultimately enters the systemic arterial system. So because of that, this area will pull the arterial oxygen tension down and have a significant effect on that, even though there are other areas with a high alveolar oxygen tension. So in summary, the alveolar arterial oxygen difference is an index of the efficiency of pulmonary gas exchange. It shows how well a given alveolar oxygen tension generated by the respiratory system translates into arterial oxygenation by means of PaO2. It turns out that it's a regional VQ ratio within the lungs that determines the alveolar oxygen tension and thus also the capillary oxygen tension of that area. Now, in an area with a high VQ ratio, that is a much higher ventilation than perfusion, that area will increase alveolar oxygen tension in that area, but also contribute relatively more to the global alveolar oxygen tension simply because this area is ventilated more than it's perfused. In contrast, areas with a low ventilation perfusion ratio will be they have a relatively higher perfusion than ventilation. They contribute less to the total average alveolar oxygen tension. While it might be low regionally in that area, it does not contribute that much to the alveolar tension in the whole alveolar compartment, but rather to the actual arterial oxygen tension, because more blood is actually leaving those areas and thus entering the systemic um, circulation. So these areas contribute more to the actual arterial oxygen tension. So we have high VQ ratios, which increase the alveolar oxygen tension, low VQ ratios, which decrease the arterial oxygen tension. And thus, the presence of high and low VQ areas in the lungs actually impair gas exchange. And this small AaDO2 in the healthy state reflects this. It reflects that gas exchange is not perfect because of this uneven distribution of ventilation and perfusion, because of the impact of gravity on the two. In lung diseases, this may be compounded in the sense that you get more areas with a high VQ ratio and more areas with a low VQ ratio. So the the VQ ventilation perfusion inequality becomes increases. So it's fundamental mechanism of impaired pulmonary gas exchange in disease. But this is just to conclude on what I just said, that it's the combination of high and low VQ ratio areas that together increase AaDO2 and thus contribute to the small AaDO2 in the healthy state, but also to vast increases in pulmonary disease states with impaired pulmonary gas exchange. So in terms of self-study objectives, I recommend that you study how the AaDO2 changes upon different changes in posture, because if you understand this, you also understand how the differing effects of gravity on the gravitational vector on ventilation versus perfusion, how that affects pulmonary gas exchange. Much of this has to do with the impact of gravity as we are exposed to it here on Earth, but studies in micro and hypergravity actually provide some pretty enlightening insight into this as well. So I recommend that you study that as well. Furthermore, the AaDO2 actually increases with healthy aging, and if you study this and understand why this is the case, you also understand a lot about how respiratory mechanics affect the ventilation distribution and ultimately gas exchange. So just to start off with these self-study objectives, I recommend these papers here, including one that we recently wrote ourselves in experimental physiology on the effect of proning on pulmonary gas exchange, which is widely used in critical care now, not least because of COVID-19. So that ends this session. Thanks for listening. Welcome to this e-learning session on hypoxia, which is part of the clinical respiratory physiology course. After this session, you should be able to define the 4 basic mechanisms of tissue hypoxia and to describe the main symptoms thereof, depending on the severity of the hypoxic insult. Furthermore, I will illustrate how the alveolar arterial oxygen difference, AaDO2, may be used to distinguish non-pulmonary from pulmonary causes of hypoxia. Let's start out with a few definitions, because what is hypoxia? it depends on where you look. Obviously, it indicates the presence of a reduced partial pressure of oxygen. But this can both be in inspired air, it can be in the alveoli per se, in the blood, or in tissue. And I put a little star here by tissue because when we talk about hypoxia in the clinical setting, we're usually talking about tissue hypoxia. And there's no well-defined threshold for when tissue hypoxia is present, and it also depends on what tissue we're talking about. But a reasonable cutoff is 4 kilopascals. So when the oxygen tension decreases below 4 kilopascals, there's probably tissue hypoxia. Now here, this is written for the mixed venous oxygen tension, that is the oxygen tension in the pulmonary artery. And that's because the oxygen tension in the pulmonary artery, the mixed venous oxygen tension, reflects the average oxygen tension in all tissues of the body. And when that decreases below 4 kilopascals, you could be pretty certain that there's a tissue hypoxia, but it may occur way before that. And in tissues such as the brain, tissue hypoxia may be present even at higher oxygen tensions. When we talk about hypoxia, there are actually 4 subtypes or 4 basic mechanisms of tissue hypoxia. One is so-called hypoxic hypoxia, or some call it hypoxemic hypoxia. And this is a condition where tissue hypoxia evolves because of a reduced oxygen tension in arterial blood. So this is just to show the normal condition here. So blood passes from left to the right in this figure, and you can see that they're passing through a tissue and releasing oxygen to the tissue in the tissue mitochondria. And the red blood cells are gradually desaturated in this process. So this is the normal state. So in hypoxic hypoxia, there's low oxygen tension and thus also a low oxygen saturation, and thereby also a low oxygen content in the blood to the tissue. And this leads to a lower oxygen tension in the tissue itself, and thus tissue hypoxia. Another type of hypoxia is anemic hypoxia. And in anemic hypoxia, the oxygen content of blood is reduced even if the partial pressure of oxygen in the blood is normalized. And how can that be? Well, that's because of reduced hemoglobin or reduced number of red blood cells. And that's what I've tried to show in the figure here. So there's a normal oxygen tension in the arterial blood, and thus the red blood cells are normally saturated in the arterial blood, but as they enter the capillary bed in the tissue, they do not have sufficient, they're not carrying sufficient oxygen to the blood, and that ultimately results in tissue hypoxia here. Another type is a so-called ischemic hypoxia. Sometimes it's also called circulatory or stagnant hypoxia. And in this case, there's also tissue hypoxia even if the oxygen tension is normalized. In this case, it's not because there's a reduced oxygen content in the blood, but there's a reduced oxygen delivery to the tissue. And that's because the delivery of oxygen to a tissue depends both on the content of oxygen in the blood and the perfusion of the tissue. And if there's hypoperfusion, that may result in tissue hypoxia. Ischemia is actually defined as tissue hypoxia due to hypoperfusion. So that's what I've tried to illustrate here by drawing a relatively narrow vessel. That's to say it's hypoperfusion. And that may both occur in a tissue due to a locally reduced perfusion because of a stenosis, a blood clot, or something else, compression of the tissue. It can also be caused by circulatory failure with the shock and hypotension globally. That's another cause of ischemic hypoxia, in which case it will be more global throughout the body. The last type of hypoxia is so-called histotoxic hypoxia. And in this case, the oxygen delivery to the tissue may actually be normal, but for some reason, the oxygen cannot get from the hemoglobin to the mitochondria where it's to be utilized. And usually that's because of some dysfunction in the mitochondria. So they're unable to, due to dysfunctions in the electron transport chain, they're unable to utilize the oxygen. So in this case, there's actually not tissue hypoxia as such, because the oxygen tension will actually tend to be high. The oxygen just cannot be utilized by the tissue or mitochondria. This is typically seen in various forms of poisoning, cyanide poisoning, for example, but it's also an element of many critical diseases we know from critical care, such as sepsis. All right. So what are the symptoms of hypoxia? Well, most of the symptoms of hypoxia derive from the most oxygen-sensitive organ of the body, that is the brain. The brain has no or very few intrinsic oxygen reserves, and thus it's the first organ to be affected by hypoxia. And here I've just used hypoxia as an example, because I think the actual arterial oxygen tensions are very illustrative to show this. So if the PaO2 is above 10.7 kilopascals, there are no symptoms, but as it gradually decreases, symptoms become more and more pronounced. Impaired night vision, dyspnea, dizziness, derealization, tingling in the fingers. When it becomes severe enough, and that is less than about 5 kilopascals, sudden loss of consciousness may ensue. And the time it takes for this to set in, this sudden unconsciousness without warning, depends on the severity of hypoxia. At very low levels, it will occur in less than a minute, as I've also shown here. Please note that exertional dyspnea is really the only symptom from the respiratory symptom of hypoxia, and many of the other symptoms are very vague, so they're actually difficult to detect, and that just shows that for example, during breath hold, hypoxia is not the limiting factor for breath hold time. That's actually the ensuing hypercapnia, because when you hold your breath, you're not ventilating, and thus PaCO2 increases gradually, actually in the resting condition with around 0.8 kilopascals per minute. And at around a PaCO2 of 8 kilopascals, you reach the so-called break point where you get involuntary breathing movements, and it also changes your whole behavior. You become what we call air-seeking, and you get anxious and panicky, and but that's actually symptoms of hypercapnia and not of hypoxia. So the symptoms of hypoxia per se are very, very vague, unless it becomes so severe that you suddenly grow unconscious. But that's also just to say that the unconsciousness associated with hypoxia can be very, very sudden. And here I'm talking about short-term hypoxia here, not the type of hypoxia you experience when you're, for example, climbing a mountain and exposed to hypoxia for days. I'll just mention a few things here about the alveolar arterial oxygen difference, because that's actually useful if you encounter a patient with hypoxic hypoxia, that is a reduced PaO2, because in that case the ADU2 may distinguish between a pulmonary and a non-pulmonary cause of reduced PaO2, because clearly PaO2 may both decrease if the patient does not ventilate sufficiently, or if the actual gas exchange within the lungs is impaired. So in a patient with a normal ADO2 and a reduced PaO2, one must, in the normal clinical setting here at the sea level, consider whether the patient is actually hypoventilating, for example, due to CNS affection, impaired consciousness, poisoning, something like that. Other causes in principle may be inspiratory hypoxia, that is breathing in air with a low oxygen fraction, or breathing in air at a low ambient pressure, but that's never relevant when you're at sea level breathing ambient air. If the alveolar arterial oxygen difference is increased, it indicates that there's a pulmonary contribution that leads to the low PaO2. And that may be caused by the same three factors that I in a previous session talked about in relation to ADO2. So uneven ventilation perfusion distribution, that contributes more to the ADO2 in the healthy state, and it's actually when the ventilation perfusion distribution becomes pathologically uneven, that's a very common cause of hypoxic hypoxia, and indeed it's the most common common cause of impaired pulmonary gas exchange. It's seen in pulmonary embolism, in the acute respiratory distress syndrome, COPD and asthma, and in interstitial lung diseases. And all of these, and pathologically uneven ventilation perfusion distribution is the main cause of hypoxic hypoxia. Right to left shunting was another mechanism of the non-zero ADO2 in the healthy state, and right to left shunting may of course also be present in some disease states, for example congenital heart disease, but also atelectasis and pneumonia may give rise to shunting of blood from the right to the left side of the lung. Lastly, impaired diffusion capacity may also increase ADO2, but it will not give rise to an actual reduced PaO2 in the resting state. It may during exercise or something similar, but not in the resting state. So even in interstitial lung disease, where there's an increased thickness of the blood gas barrier, an increased distance from the alveoli to the capillaries, it's not the main mechanism of hypoxic hypoxia. It is actually an uneven distribution of ventilation relative to perfusion. So in summary, the four basic mechanisms of tissue hypoxia are hypoxic, anemic, ischemic, and histotoxic hypoxia. The symptoms of hypoxia mainly originate from the CNS, and severe tissue hypoxia, because it mainly affects the brain, it's life-threatening and may cause sudden unconsciousness. In terms of self-study, I suggest that you read about the mechanisms of cyanosis and how they relate to these four types of hypoxia that I've described in this session. Furthermore, it's very useful to sit down and take these four parameters here: arterial oxygen tension, oxygen saturation, oxygen content, and mixed venous oxygen tension and infer how they may all change during these 4 types of hypoxia, because that really gives you an understanding of the integrative pathophysiology of this. Furthermore, I recommend that you read about acclimatization to high altitude, as well as to the physiology of breath hold and diving, which I briefly alluded to when I discussed the symptoms of hypercapnia during breath hold. And to start with, I thus suggest that you read these papers here, both about the oxygen sensitivity of the brain, the different types of hypoxia, and also the fundamental mechanisms of hypoxemia and hypercapnia in a broader sense. That ends this session, and thanks for listening. Welcome to this e-learning session, which is part of the clinical respiratory physiology course. This time on chemoreception. So in this session, I will enlighten you in terms of the so-called CO2-centric view on breathing. So after this session, you should understand the principles of carbon dioxide transport in blood, understand the mechanisms of chemoreception in respiration, and understand how the respiratory system acts as a CO2 stat that matches ventilation with metabolic demands of the body in various conditions. Let's start out by taking a look at CO2 transport through the whole respiratory system. So in atmospheric air, there is no relevant amount of CO2, at least not physiologically relevant amount. So we assume that the CO2 fraction in ambient air is 0. In fact, this is a fundamental principle for many respiratory physiology calculations, for example, dead space calculations, and also alveolar ventilation equations. So there's no CO2 in the inspired air, and thus still no CO2 in when the air enters the airways and is vaporized. However, in the alveoli, there is an oxygen tension which is normally around 5.3 kilopascals. Please note that all this CO2 is actually derived from the blood and thus released to the alveoli by gas exchange, by diffusion. And all this air then leaves the alveoli by all the CO2 leaves the alveoli by ventilation. The CO2 tension in end pulmonary capillary blood is also 5.3 kilopascals, and they're actually under, at least not in the healthy condition, any measurable differences between alveolar and arterial CO2. So this is somewhat different than for oxygen, where we have the alveolar arterial oxygen gradient. This difference depends on between oxygen and CO2 depends on 2 things. One is the shape of the oxygen dissociation curve relative to the CO2 dissociation curve, which I'll describe in a short while, as well as different diffusive properties of CO2 versus oxygen. CO2 is much more soluble than O2, but the main factor accounting for the small or immeasurable difference between alveolar and arterial CO2 is actually the shape of the dissociation curve. All right, so in mid-capillary blood in the tissues, the CO2 tension increases because CO2 is released from the tissues where the metabolic processes take place. And in mixed venous blood, it's around 6 kilopascals. So blood with a CO2 tension of 6 kilopascal enter the pulmonary capillaries, and CO2 is then released to the alveolar compartment. Equilibrium is reached so that it becomes 5.3 kilopascals within the blood before it leaves the pulmonary circulation. That's pretty much the story of it. But let's take a look at the CO2 production in the tissue. So normal CO2 production would be around, in the resting state, would be around 200 mLs of oxygen per minute, which is more or less 9 millimoles per minute. Assuming that a resting individual has a cardiac output, just for the sake of example here, of 4.5 liters per minute, that means that 2 millimoles of CO2 are released to each liter of blood that perfuses the tissues. As it enters the blood, it is transported in three forms. One is physically dissolved. That's actually the fraction that gives rise to an actual PCO2, partial pressure of carbon dioxide in the blood. And the other two means of transportation is conversion to bicarbonate. So the CO2 enters the red blood cell, where it is converted by carbonic anhydrase to bicarbonate, and bicarbonate is then released from the red blood cell again by the so-called chloride shift. That's the second means of transportation. And the last is hemoglobin bound in the form of carbamates. So it undergoes a chemical reaction with the hemoglobin and is transported in the hemoglobin bound form. A matter of dispute is how much each of these forms of transport contribute to the overall CO2 carriage in blood, and it differs somewhat between different textbooks. So I've looked up some of the old sources, including a chapter from the handbook of classical chapter from the handbook of physiology, where I found some data to make appropriate calculations. I provide the reference at the end of this session for you. But just to say that I've used these values here for plasma levels and red blood cells, values of the partial pressure of CO2, the solubility of CO2, bicarbonate concentrations, carbamate, and also taking changes in hematocrit into account. And based on these data, I have myself estimated how much CO2 is transported by each of these means. So some sources state that 10% is physically dissolved, 20% is transported as carbamate, and 60 to 70% is transported as bicarbonate, whereas others state that 90% is transported by bicarbonate and the rest by carbamate and physically dissolved. And according to these data here, when you do the maths, it supports the latter. Let's take a look here. According to this data that I just showed you, 5% is physically dissolved, 93% is transported as bicarbonate in arterial blood, and 2% as carbamate. And after passage through the systemic capillaries, it's pretty much the same. So about 90% being transported as carbamate makes perfect sense. So these are the figures I would go with, and about 5% in the physically dissolved form. Now, even though only 5% are transported in the physically dissolved form. It is so that the so-called CO2 dissociation curve is somewhat linear. It's at least more linear than the sigmoid-shaped oxyhemoglobin dissociation curve, and that's what I'm trying to show here. Which basically means that that PaCO or PCO2 actually correlates closely with total CO2 levels in the blood. And you can argue that PaC, or not PaCO2, sorry, I keep saying that, I just mean PCO2 in blood is an index of total CO2 levels. And it's actually used by the chemoreceptor system of the respiratory system to monitor CO2 levels. What these data here also show is that when CO2 is released from the tissues, 2 millimoles are released into a pool of CO2 that's already present in the blood. There's 22 millimolars present in the blood that's entering the capillary bed, and a small bit of CO2 is then added to that and released again once the blood gets to the lungs. And that means that there's a rather large reserve of CO2 in the blood, which is pretty neat because this enables the respiratory system to adjust CO2 levels in acid-base homeostasis. But in any event, PCO2, and specifically arterial PCO2, PaCO2, is continuously monitored by the chemoreceptor system, and that consists of chemoreceptors in the carotid body, the aortic arch, and also central chemoreceptors. These also monitor PaO2 levels and pH in blood, but as I will show you in a minute, these are less important during the normal regulation of breathing. So the peripheral chemoreceptors, they sense both CO2, oxygen, and pH, and they're located in the carotid body and in the aortic arch, and provide feedback to the central nervous system through the glossopharyngeal and the vagal nerve. This system actually responds rather quickly, so if these receptors are stimulated, they cause a change in minute ventilation within a minute, actually usually within 30 seconds, so it's a rather rapid system. They do not cause large or not even sufficient changes in ventilation to correct for any detected change. And this is where the chemoreceptor system becomes important. It's not one chemoreceptor, but it's a whole network of chemoreceptory bodies placed in inside the blood-brain barrier within the brainstem. These do not detect oxygen or pH in blood. They actually only respond to the local pH around them. And the pH around inside the extracellular space of the brain is mainly determined by CO2 in the blood, because CO2 passes the blood-brain barrier in contrast to hydrogen ions and bicarbonate, and can then reduce, if CO2 passes, it will reduce pH in the brain extracellular space, and that will stimulate the central chemoreceptor system, which will then increase ventilation and reduce PaCO2. That's basically how it works. So it's a network of sensors in the brainstem and responders to changes in brain extracellular pH, which it mainly depends on CO2 in blood. However, other factors, for example, pathological processes within the brain, directly affect pH that will also affect breathing, which we see in some conditions such as neurotrauma or neuroinfection, brain ischemia, and so forth. This system is not as quick as the peripheral chemoreceptor system. It actually takes a few minutes for it to cause to change ventilation upon an acute change in arterial CO2. But it does cause, in contrast to the peripheral chemoreceptors, it causes a larger change in ventilation that's sufficient to to compensate for the initial or to correct the initial change in CO2. Yes, so it responds within 1.5 minutes, sometimes a bit longer than that even. So, all right, so let's look at the chemoreceptor feedback loop. What I've marked here with blue is the normal range for PaCO2, about 4.5 to 6 kilopascals. And what we can see here is that if PaCO2 is increased, that will increase ventilation. That's because it stimulates both the peripheral and the central chemoreceptors, and this will together increase ventilation. You can do this experimentally by letting people inhale CO2. Cause a marked increase and exponentially increasing increase in ventilation, and thus in alveolar ventilation. And what we can see here, that within the normal range, it is near linear, and that means that CO2 is tightly regulated even within the normal range. Even small changes in CO2, PaCO2, will cause changes in ventilation, thus stressing that even under normal physiological circumstances, PaCO2 is a significant stimulus for changes in ventilation. If there's another concurrent input to the peripheral chemoreceptors, such as a reduction in PaCO2, the PaO2, the response to CO2 is enforced. So at a lower, if you at a lower PaO2, a given change in PaCO2 will cause greater change in breathing. So there's physiological interaction at play here. Let's look at the PaO2. So this curve looks somewhat different, and actually within the normal range for PaO2, here I marked it as about 11 to 13.3 here, I think. You can see that it's almost flat. So within the normal range, small changes in PaO2 will not change ventilation. Actually, if at normal capnia and if there's no acidosis or no acid-base disturbance, you actually need to PaO2 has to reach a threshold of around between 8 and 10 before any notable changes in ventilation occur. So you have to be rather hypoxemic before ventilation is stimulated. However, if you're concurrently hypercapnic, this is shifted, so even smaller changes in PaO2 may cause significant changes in breathing. Lastly, this is just to show pH. Again, the normal range here is marked with blue, and what you can see is that that you need a substantial decrease in pH before it directly affects ventilation. This changes if the patient is, for example, concurrently hypoxemic, but pH per se is not a strong stimulus for ventilation. So together, this shows that PaCO2 is the single most important stimulus of the three under normal physiological circumstances. This brings me to the alveolar ventilation equation, which I've shown here below. It basically says that alveolar ventilation is the fraction between the body's CO2 production and the fraction of CO2 in alveolar air, and you can rewrite that so you get alveolar CO2 in the denominator. And again, you can actually replace that with arterial CO2 because they're very similar as showed you before. But the relationship is shown here. So now, now alveolar ventilation is the independent variable here. And when you increase ventilation, you reduce PaCO2 both in the artery and in the alveoli. The other curve that I've shown here is how it is shifted if the body's CO2 production is increased. That will shift the curve to the right. And the chemoreceptor feedback loop is what we just saw before. Basically, that's what I showed you just before when I went through the 3 different chemoreceptor stimuli. But we can combine these 2 curves, so we get the integrative view, or the CO2 centric view. So now we both have alveolar ventilation and PaCO2 as stimuli and responses. And the point is that it shows how PaCO2 and ventilation is regulated, and how PaCO2 will be kept, how the respiratory system will go to wide extent to keep PaCO2 within the normal range. So where the 2 lines cross, that's what alveolar ventilation is at a given point, and PaCO2 at a given PaCO2. So let's see what happens if we modulate the system somehow. Because we can reset the chemoreceptor. It can be rendered more sensitive by different stimuli. If that happens, it will be shifted to the left. So what happens now? Well, the patient increases ventilation, so the PaCO2 decreases, and we see that in a lot of the patients. These are patients that hyperventilate for various reasons, but you need that. If a patient is hypocapnic, there must be a shift in the chemoreceptor sensitivity, or the patient must be voluntarily hyperventilating. That is, of course, another option. But what can shift the chemoreceptor curve in this manner? Well, I'll get back to that. 2 of the things that can shift it, we've already seen it actually, because that was changes in pH and the hypoxia. This is basically just a different way of showing that. It's a CO2 centric view, so now we're just viewing it all from the point of CO2. So before I showed you how PaO2 and pH chemoreception can be shifted by CO2, but you can actually just look at it this way and consider it a resetting. So now, because there's concurrent acidosis or hypoxia, for example, the normal range, the respiratory system considers or instigates a lower normal range, so to say. So it targets another PaCO2, which means that ventilation must be increased. Hypothermia and enhanced sympathetic drive, they have the same effect, and that's why we see that many patients hyperventilate in the clinical setting, and for example, why patients with hypoxemia, they hyperventilate even though that their PaO2 is nowhere near the threshold, the chemoreceptor threshold. If they're concurrent febrile, or stressed or anxious, or bleeding or whatever, that will shift the chemoreceptor. That will reset the chemoreceptor to target a lower PaCO2 and thus induce hyperventilation. What happens during exercise? Well, during exercise, PaCO2 is actually kept relatively constant until the lactate threshold is reached. And let's see how that can happen. Well, when you exercise, you increase metabolism, and that actually means that the alveolar ventilation curve is shifted to the left in this manner, which I also showed you before. So if nothing else happened, this could actually lead to a state of hypercapnia, as you can see. But during exercise, um, the chemoreceptor curve is actually shifted slightly to the left, so that the person remains within the normal range for PSU2, and often it's completely unchanged. Then when the lactate threshold is increased, this indicates that what happens at that state is also that arterial pH starts to decrease. So there's another stimulus for the chemoreceptor system, and that shifts the chemoreceptor curve, and thus you get actual hyperventilation with hypocapnia, which you see during when the lactate threshold is passed during exercise. So that's basically the mechanism of that. What happens during pulmonary gas exchange? Well, when it's arterial and not alveolar CO2 here on the x-axis, it will actually mean that this curve is shifted to the left as well, because that basically implies that for a given alveolar ventilation, CO2 is higher. So ventilation is less efficient at excreting CO2, so to say. All right. So here you can see what happens with impaired pulmonary gas exchange. If ventilation is unaffected or chemoreception is unaffected, well, then you will actually have an increase in PSU2. Not necessarily above the normal range to start with, but it will affect CO2. However, there are often other inputs at the same time. For example, if it's a pulmonary embolism, there'll be concurrent hypoxia, sympathoexcitation. If it's a patient with a severe infection, there'll be fever, and the curve is thus shifted. The chemoreceptor curve is thus shifted leftward, and you then get a state of hyperventilation. Yeah. Same mechanisms again for the left shift of the chemoreceptor curve. What happens with impaired pulmonary gas exchange in some cases, such as COPD, though, is that its pulmonary gas exchange is getting worse and worse, and this curve is shifted more and more to the left. So PSU2 increases. And this is often complicated by reduced chemoreceptor sensitivity with time. That's a hallmark of many diseases, and you then get a state of chronic hypercapnia. This is not necessarily chemoreceptor dysfunction. It can also be neuromechanical failure. So for a given respiratory drive from the central nervous system, the whole neuromechanical system is unable to provide a sufficient level of ventilation mechanically. And this also applies to respiratory exhaustion, which you sometimes see in patients with acute respiratory failure, including patients with asthma. They may experience respiratory exhaustion, and that will also cause such a right shift of the chemoreceptor curve, and thus progressive hypercapnia. Impaired consciousness can have the same effect, because that affects both the actual output from the central nervous system, but also chemoreceptor sensitivity. Lastly here, I just want to highlight the main mechanisms of reduced chemoreceptor sensitivity, because that will obviously in itself increase PaCO2, even without impaired gas exchange, although impaired gas exchange will compound this. So during sleep, there's actually a slight right shift of the chemoreceptor curve, so a slight increase in PaCO2 during sleep. Opiates also right shift the curve, and so does anesthesia and unconsciousness. And of course, it could be right shifted to the extent where a patient stops breathing completely, because the intrinsic respiratory rhythm from the central nervous system provides a very, very low minute ventilation per se. I've actually looked for the exact number for that, or estimates of it, but I haven't found them. Please contact me if you should have any data that could suggest or give an adequate estimate of what kind of level of ventilation the CNS provides without chemoreceptor input, completely without it. So I hope I've convinced you by now that PaCO2 is the main driver of ventilation in the healthy state. So chemoreceptor feedback from CO2 in the bloodstream continuously drives and modulates ventilatory drive from the CNS. And ultimately, this functions to match this tight regulation of PaCO2 functions to match the body's metabolic the metabolism in the body with ventilation. In terms of self-study, I suggest that you study the Bohr effect and the Haldane effects, and think about how each of them contribute to optimizing the transport of gases in blood. To follow up on the curves that I have just discussed the whole CO2-centric view, I would also encourage you to read about CO2 narcosis and read it in the light of these curves and this whole concept of CO2 centrism. Furthermore, I encourage you to study how chemoreception is involved in both the correction and compensation of acid-base disturbances, and also read a bit about respiratory rhythm disturbances, which are basically all about this whole feedback loop I've discussed in this session. And the recommended reading is here, and much of the data that I use for my calculations of CO2 transport in blood is based on Clocke here in the Handbook of Physiology, and I think I may have supplemented with a bit of my own data just to be able to complete all the calculations. So remember, they're just estimates, but it's just to exemplify that bicarbonate is the main means of transport of CO2 in blood, and it's closer to 90% than to 60%, which are the two often quoted fractions in different respiratory physiology textbooks. Yes, and I also recommend these other papers here on chemoreception. So that ends this session here. Thank you so much for listening.